Well, neovascular glaucoma is one of the most difficult forms of glaucoma for us to manage. It's a form of angle closure, but it's really important to recognize that it is not pupillary block angle closure, so it's not a type of angle closure where iridotomy would be of any benefit. It is caused by new blood vessels forming in response to retinal ischemia. The vessels grow into everything, including the meshwork. They're associated with a membrane, and that membrane can by itself obstruct aqueous outflow and also can contract and pull the iris up, leading to peripheral anterior synechia formation. It is felt that ischemic retina produces vasogenic substances that stimulate the growth of new vessels, such as vascular endothelial growth factor. The vessels are accompanied by a membrane that really you can't see, but that membrane by itself can restrict aqueous access to the angle, even in areas that look open, and then eventually pulls the iris forward. Intraocular surgery, like cataract surgery or vitrectomy, can break down the natural barriers and increase the access of these vascular growth factors into the anterior segment and increase your risk for anterior segment neovascularization. There are lots of causes of neovascular glaucoma. These are the big three: diabetes mellitus, central retinal vein occlusion, that's what's pictured here, an ischemic vein occlusion. Sometimes that's called 90-day glaucoma because it seems to occur around 90 days, but I found that to be a fairly unhelpful designation. Or carotid artery occlusion. These are the three biggest. You should really consider carotid artery occlusion in somebody who has extensive angle closure, but an intraocular pressure that's not sky high. So if the angle is completely closed, you would expect the pressure to be 60 or 70, and if it's 25, then you might lean more towards carotid artery occlusion. And if that patient undergoes an endarterectomy and increases the flow to the eye, that can cause a pressure to go very, very high. And then there are a host of other disorders that can cause neovascular glaucoma and neovascularization in the angle. I'm not sure how helpful it is to memorize long lists like this, but you should have access to it. Things like chronic retinal detachment, giant cell arteritis, radiation, and tumors. The one outlier here is the last one, Fuchs heterochromic iridocyclitis. That's the subject of another whole lecture in this series, but that causes neovascularization in the angle, but for whatever reason there's no membrane and no neovascular glaucoma. What we see is vessels around the iris. They often start at the pupillary margin, as we see in these two images here, much harder to see in a darker colored eye. Later they can be diffuse over the entire iris surface, and they can become quite striking. The slide on the left, you can see that the vessels are actually growing across the surface of the lens, and in this image on the right, the membranes have contracted and pulled the iris completely out of the picture, other than inferiorly where you can see vessels growing up onto the lens. In this area here, really pretty striking neovascularization. This patient has marked neovascularization in his left eye, his heterochromia from that, and in the right image one can see a hemorrhage from these very lush vessels on the surface of the iris. In the angle, you can see neovascularization, and early on, there, like in this picture here, there may not be synechia, but one can see these fine vessels that cross the spur and then actually branch or arborize on the meshwork. Sometimes there's a red blush to the trabecular meshwork, and then that membrane that accompanies the vessels, as we said, impairs the outflow, and then it's important to know that these vessels can be present in the angle without any iris vessels. So don't be relaxed if one has a patient with a central vein occlusion or bad diabetes and the iris looks normal. It's still important to do gonioscopy. Later, these membranes can pull the iris over the angle and cause synechial angle closure. As you can see here, this iris is pulled up over the angle. And because the corneal endothelium is normal, the synechia generally do not extend past Schwalbe line, unlike ice syndrome, where they go very high. In this patient, this light beam traveling across the iris, and one can see the internal and external parts of the corneal wedge that never come together because the trabecular meshwork is very far below the iris in this closed angle. A few movies here, you can see iris neovascularization there at the beginning, and then in the angle, marked neovascularization with synechia formation. Open angle here, iris pulled up into synechia elsewhere. Pretty active disease. You see a lot of vessels still present in this eye. Even more marked example with just huge blood vessels on the surface of the iris. And then this marked neovascularization in the angle, lots of blood present. The angle here is completely closed. We don't really see any meshwork at all. Looking inferiorly, all we see is blood. We don't really see the trabecular meshwork. This is an eye with severe proliferative disease and lots of blood. The iris is completely pulled up over the trabecular meshwork. And just a really interesting example here where the iris is pulled out and up, giving us an uncommon view of the ciliary processes, which you shouldn't see in routine gonioscopy. There's a big gap between the lens and the iris here that shouldn't exist. We treat these by treating the underlying pathology. VEGF inhibitors have been a huge advance. Panretinal photocoagulation for proliferative diabetic retinopathy. For other conditions such as vein occlusion and ischemia, the indications for PRP are less clear. VEGF inhibitors like Avastin and Lucentis have proven to be very effective in drying up anterior segment neovascularization. The glaucoma we treat with aqueous suppressants. One would avoid trabeculoplasty. There really is no access to the angle. No cholinergics like pilocarpine. Trabeculectomy with active neovascular glaucoma has a poor prognosis, but these days with VEGF inhibitors, getting everything quiet, it is reasonable to consider trabeculectomy or tube shunts. But again, if the eye is not quieted, these shunts can become engulfed in a fibrovascular mass. Cyclophotocoagulation if all else fails or if the visual prognosis is very poor. Cyclophotocoagulation is a challenge in these individuals because they often have no outflow, and so they need more aggressive laser treatment than somebody with other forms of glaucoma where there's a little bit of outflow. Key points here: very common secondary angle closure glaucoma, very difficult to treat. It is not pupillary block angle closure, so don't do a laser iridotomy. One can have neovascularization of the angle without neovascularization of the iris. So it's important to do regular gonioscopy on diabetic patients, people with central vein occlusions, etc. The most common causes are diabetes, central vein occlusion, carotid vascular disease. And we treat it by treating the underlying cause. Very tough disease to treat. And so, unfortunately, in our practices, we'll all see a lot of neovascular glaucoma.